Hello and welcome everybody. Annie Gibbins here, the CEO of Glaucoma Australia. Welcome to Glaucoma Week and thank you so much for taking the time to tune into this fantastic Facebook Live. We have tonight joining us Dr. Ridia Lim and her glaucoma fellow, Dr. Kalliopi Giannopoulous. And we're going to be talking all things glaucoma treatments because I tell you what, most patients get very confused as to why there are different treatment options and why we're all different. And I'm so looking forward to Kelly's presentation today. So the way it's going to work is Kelly is going to do a present to all of us, and you can definitely be feeding in your questions into the Facebook Live chat. So make sure you pop those in. After Kelly's finished, I will then go and ask Kelly and Dr. Ridia what their responses are to those amazing questions. So I'll just give you a little bit of background who these amazing esteemed ladies are. Dr. Lim, Dr. Ridia Lim is a senior ophthalmic surgeon and a glaucoma subspecialist, and she's got more than 2 decades of clinical experience in ophthalmology. So basically you are very, very blessed tonight, those tuning in. Her positions include senior lecturer at the University of Sydney. She's also the vice chair of ANSCUS, which is the glaucoma group of specialists, the board of Safe Sight for All, and scientific program executive for her college, which is called RANSCO. She's dedicated to delivering state-of-the-art medical and surgical care for all of her patients, and she's a super enthusiastic teacher and gorgeous lady. She's spoken at local, national and international levels. She's also in books and peer review articles. She's a scientific reviewer. Oh my goodness, this lady has done it all, and I'm so thrilled that she's going to be able to answer your questions tonight. Dr. Kalliopi Giannopoulous is an ophthalmologist who studied she's over in Greece. She graduated from a medical department at her military school of combat support officers. Doesn't that sound interesting? She completed her ophthalmology training in Athens, and she obtained a master's degree in ophthalmic imaging in public health. So she's super excited about to be able to share her knowledge and skills with you today. And I'm going to now hand it over to Dr. Kelly.
Hello, everybody. I'd like to welcome you to this very interesting session and thank Glaucoma Australia for giving this very nice opportunity. So can we start with the presentation? So the topic today is treatments in glaucoma. I'm gonna do a very short introduction. Glaucoma affects 80 million people around the world. And in Australia, 2 out of 100 people are going to be affected by glaucoma at some point at their life. So glaucoma is an umbrella term. It is a group of eye diseases that have common ground that they damage the optic nerve. And the factor that we can modify is the intraocular pressure. But what do we mean when we say intraocular pressure? The eye produces the aqueous humor, which is the fluid of the eye. It is produced, it flows into the eye and drains out from the drainage system. When there is an imbalance between the production and the drainage of the aqueous humor, then the intraocular pressure is increased and the optic nerve is damaged. So we are diagnosed with glaucoma. One is diagnosed with glaucoma. What is very important to know is that glaucoma is not curable. So whatever treatment we do, whatever management we do, is only to stop progression. And the treatment is divided in 3 categories: medication, laser, and surgery. Medication, eye drops, we're all familiar with them. They are the first line treatment, and there are different categories of eye drops, glaucoma eye drops. They can work either by increasing the outflow of aqueous humor or decreasing the production of aqueous humor, or might have a combined mechanism of action. A patient can be using 1 drop, 2 drops, a combination. All that has to do with how low we want the intraocular pressure to be. If the patient has got other systematic health issues that don't allow him to use drops from one category, or how he tolerates the drops. It is very important to know that glaucoma treatment is a lifelong commitment. In many occasions, glaucoma doesn't have any symptoms. That doesn't mean that there is no disease. And unfortunately, high rates of non-compliance have been reported. So we have to say how important it is for the patient to use his drops every day at the hour he should use them. And when somebody starts using drops, his eye care professional should show him the right way, the right technique to use them so he can have the maximum result and the minimum side effects. In some cases, we can also use pills in order to control intraocular pressure. That is usually in emergency situations where the intraocular pressure is very high, or as a short-term measure prior to more definite treatment. And that would be either surgery or laser. So coming to laser, there are different types of laser that have to that are applied to different types of glaucoma. I'm going to start with the newest laser, selective laser trabeculoplus, DSLT. It is used in open angle glaucoma, and the laser is aimed at the drainage system of the eye. It improves the drainage. It is relatively safe because it doesn't damage the tissue, so it can be done again, it can be repeated. And it is usually used as a supplement to existing medication. Sometimes a patient might even do the laser and not use drops afterwards, but the laser does not last forever. It has got a limited time where it is effective, a few years. We've got some other types of laser, peripheral iridotomy and laser iridoplasty, that are used for angle closure glaucoma. They can be used in emergency situations where the drainage system of the eye has been closed and the intraocular pressure is very elevated, or they can be used in eyes that are anatomically predisposed to have such an acute crisis in order to protect them. Finally, with the laser treatments, we've got cyclodide treatment, cyclodide laser. It works in a different way. It destroys a portion of the tissue that produces the aqueous humor. So it is used in cases where medication and laser is not enough, when we believe that surgery could be difficult or is of no use. So it controls the intraocular pressure and sometimes the pain that can be caused by a high pressure. So let's move on to surgical management. Here we've got two big categories. The first one is the conventional surgery, and the other one is the newest mix we're going to talk about. So when we're talking about surgical management, we've got different types of procedures, but the gold standard, the one that is used most of the times, is trabeculectomy. And on the other hand, we've got the glaucoma drainage devices that are implanted into the eye. All of them have got the same goal, to create a new pathway for the fluid to drain out of the eye into a created pocket, a created pleb, a created reservoir, where it can be drained in a controlled way, and it is absorbed into the tissues around the eye. So surgical management is used in cases where we have glaucoma that could be advanced, complicated glaucoma, when we want the intraocular pressure to be very low. And the operation itself, as well as the post-operative care, especially the first period after the surgery, is very important. And we've also got mix during the last years and last decades, minimally invasive glaucoma surgery. There is a number of mixed procedures, and they work in different ways, and they help the fluid inside the eye drain out via different routes. Some of them can be combined with cataract surgery. Some can be done as standalone procedures. And usually, most of them are used for mild to moderate glaucoma. So they actually are a step between medication laser and conventional therapy, conventional surgery, sorry. A very common question that we get from glaucoma patients is that, okay, I take my drops, I did my laser, I did my surgery. What can I do when it comes to my diet or my lifestyle or my exercise in order to help with glaucoma? So there has been a great deal of research in this area, and actually, the results are quite controversial. It's not so obvious, not so evidence-based what one can do. What has been very much studied and seems to be positive and helpful for glaucoma is a diet that is rich in antioxidants and nitrates. We can find those in fruit and in dark leafy greens. Also, vitamin B3 has shown to be positive for helping with the progression of glaucoma, and also omega-3 fatty acids. But they are mostly useful for ocular health and retina health. Still a bit controversial about glaucoma. What is definite that plays a very important role is cardiac and vascular health. So anything that could compromise cardiovascular health, diabetes, hypertension, increased body weight, smoking is something that should be avoided, or in case it exists, to be controlled and treated. And in the same way, aerobic exercise is good for cardiovascular health. So for the health of the optic nerve too, but there should be some caution in specific exercises. For example, some yoga positions where the head is beneath the heart level, it's considered that they can create a raise and increase in the intraocular pressure. Maybe swimming with very tight swimming goggles, and also high intensity workout can cause oxidative stress, so it could affect maybe the optic nerve. Generally, it is a good idea to avoid activities that can induce Valsalva maneuvers. Such activities could be, for example, playing a big wind instrument, and also something that has been found to have a relation with glaucoma progression is sleep apnea. So in case this disease exists, it should be treated. In any case, what is advised by the American Academy of Ophthalmology is for glaucoma patients to have a healthy lifestyle with a diet high in antioxidants and nitric oxide, to do moderate exercise, improve their sleep practices, and avoid using tobacco. Take-home message: glaucoma is a chronic, progressive, irreversible disease. In many cases, it is asymptomatic, so it is very important to remember the compliance to therapy. Therapy can be either medication or laser or surgical treatment. The eye specialist will advise what is appropriate for each patient, and lifestyle and nutritional changes may complement, but in no way can they substitute conventional glaucoma treatment. Thank you very much.
Thank you so much, Kelly. That was really, really interesting. And I think you made it very, very clear, and lovely, lovely slides. We definitely do have a few questions coming in from our live feed. So I will just shoot them over to you, Dr. Ridia. One of our listeners says, I have been monitored for narrow angles for a year now. By when should a person get iridotomy laser when they have narrow angles?
I think that we have some criteria around what we see clinically when someone should have an iridotomy. And possibly about a decade ago, we did more iridotomies than we do now. And that's because a big study came out that looked at a certain groups of people that we thought were predisposed to acute angle closure, and we found lower rates than we expected, and that was called the ZAP study. That doesn't apply to everybody. That was basically in 60 to 80-year-old Chinese, the Chinese population. But in general, we don't just do iridotomies on angles that are narrow. We wait until there are some like stickiness inside the drain where it starts to stick down, and we call them synechii, or we wait until their intraocular pressure becomes elevated, or they start to develop glaucoma, glaucomatous optic neuropathy. So we have, although iridotomy is a very safe laser and we do them all the time, we do like to make sure that the patient actually requires it. The other thing to note is that not all angle closure is equal. So the iridotomy takes care of one mechanism in angle closure, and that's when fluid pressure is pushing the iris forward and narrowing the angle. So because many of our patients have more than one reason for the angle closure, you have to keep in mind that iridotomy is not a cure. And just because you've had an iridotomy doesn't mean that you've been cured of the angle closure.
Beautifully.
So I guess in your case, every case is different. I find angle closure so fascinating because every case of angle closure could have more than one mechanism, and everyone's slightly different, and you have to individualize when the laser is done.
And I think that's a key point, and that's one that constantly surprises patients when they call in our to educator SAPNA, saying, "Well, why am I different?" or "What how complicated can it be?" And the response I'm hearing is actually we're all complicated, and there's many factors, and those decisions are made very individually based on a variety of factors. Would that be correct to say?
Very, very much. So sometimes you might choose to do an iridotomy when we haven't quite reached the clinical criteria that we have. And that could be because someone's diabetic and they need multiple dilated examinations, which can exacerbate an acute angle closure attack. Or someone might be living remotely and they're far away from services should they have an attack of acute glaucoma. In fact, acute angle closure in these predisposed eyes is not common, but it can be devastating. Yes. And so we have to balance all of these risks and benefits.
Fantastic. Another question came through. Are all glaucoma surgeries available in both public and private clinics and hospitals?
Yes and no. So, of course, all public hospitals, they're not the same. Each public hospital will depend on what services they have, what they can offer. I can speak for Sydney Eye Hospital. We have at Sydney Eye Hospital everything that we can offer privately. So every glaucoma surgery that I can do in private practice, I can also do at Sydney Eye Hospital. That includes all of the newer mix operations, the stents, the glaucoma filtering surgeries, and the tubes.
However, if you were in a rural or remote area, how would that differ?
Well, some of the bigger hospitals in Sydney, like Westmead, Liverpool, Concord, North Shore, RPA, they would also offer glaucoma surgical services, but what they differ will vary depending on the hospital. Of course, in the country, it is quite different again. We find that we're referred many patients from the country for that reason. And, it would be great one day when we have services for our public patients that covers all of New South Wales. But yes. Many patients, unfortunately, right now have to travel.
Yeah, and that's a hard reality, and certainly has had personal health costs during the pandemic, which we don't have time to talk about today, but we certainly feel for those people. I've got another question come in. Can glaucoma surgery be reversed if it doesn't work? It's a big...
Yeah, I guess because as Kelly explained so beautifully, glaucoma surgery is not one operation. We do many different operations. And so let me just start by the simpler ones, which are the newer MIGS devices. And they're like the trabecular stents. And if they don't work, and they sometimes don't, there's nothing to reverse as such. We just leave them in and they don't create any problems. Glaucoma tubes, if they don't work or they don't function enough, we still leave them in. Now, the one time we might reverse the operation, maybe the glaucoma filtering operations, and that's because some of those operations like trabeculectomy, deep sclerectomy, or other variations where we create these pockets where we create a drain made of yaw tissues, and they're called blebs. And sometimes those blebs can become problematic. Either they overdrain and create problems with vision, or they become uncomfortable, or they can lead to infection. Sometimes we have to reverse those, and we do that by opening things up and creating a closing off the drain, usually using a patch graft from a donor.
Fascinating. I've got a few questions coming in now on eye drops, if that's okay. One of the questions is, how long would a specialist keep you on an eye drop brand or type before deciding that they're not the best choice for you, that you might need a different type of eye drop or maybe even go to laser?
Well, I mean, I think that it really depends. I think that if it doesn't work, I mean, whenever you start treatment, you give the patient, you offer them either, let's say at the beginning when they're diagnosed, you would offer them laser or an eye drop. Both are effective. The patient actually ultimately has the choice once that they are given the facts about what the benefit is of each is. Now, when you are on multiple medications, not many people, and I think it's completely fair, not many patients can adhere to that many medications. It's difficult. I find patients incredible. Sometimes they can adhere to multiple medications, but most people cannot, and understandably. Either they're having side effects from treatment, or it's difficult to use that many drops. I think that also the other thing that you have to factor in is if someone is using that many drops, it's usually because you're not at the target pressure that you want to be at. And if that's the case, you should be thinking, as the clinician, you should be thinking ahead about the possibility of surgery. And if you are on multiple medications for many years, creating redness and allergy and drop side effects, you're creating a place for poor surgical outcomes, because we're going into a space that's been having years and years of preservatives, toxicity, side effects, and trying to create a drain in that space that works. So it's always a balance, between the pros and cons of each treatment. I think that most people tolerate 1 drop a day reasonably well. When they have more than 1 drop a day, adherence to that treatment drops off. And let's say more than 3 drops a day it's quite difficult for any patient.
Yeah, I can imagine. It certainly would be for me. So I'm quite happy to say I would find that very challenging. And I know that for the people who ring up for our helpline to ask about those questions. I thought it was fascinating that you responded that ultimately the patient decides, because we feel that when we go to a specialist, that decision will almost be, well, you do need to do it this way. And what you're saying is there are choices, and that patients will become informed of the pros and cons of different options, and ultimately they will make that decision, with the doctor, but primarily that it is their choice in the end.
Absolutely. And Annie, you probably know that in recent years, we used to offer SLT laser only as adjunctive therapy, something you add on when the drops weren't enough. However, a few years ago, a really fantastic study came out called the LIGHT study, And they looked at whether we should do primary eye drop therapy or primary laser for patients with glaucoma, and also ocular hypertension patients. And I think they were really, the first thing they were actually looking at is quality of life. You know, was your life better if you took a drop first or if you took SLT first? Because I think deep inside they felt that the SLT would give you better quality of life. But really interestingly, they found that with one, starting with a drop and starting with SLT had similar quality of life outcomes at 3 years. But you know, SLT does surprisingly well. You know, you can start with SLT, and they found that the SLT group did better in the long run as far as needing less surgery goes. So, but I find that if I offer patients SLT or drops and give them exactly the same evidence, patients will make a choice about that. They hear the evidence and say, oh, absolutely, I'll start with drops, or absolutely, I'll start with SLT. And it's, you know, it's a personal choice. We're here to guide you through the available evidence.
Yeah. Oh, yes, I know, because I would automatically go SLT straight up if it was me, because, you know, if I can do that once instead of having drops. But then other people would not think that. They'd go drops. They'd rather, you know, do that. I think it's interesting that we often think of things on a sliding scale as well. We think of drops, then laser, then surgery, then, you know, more extensive surgery. Whereas what we are actually saying is that it's not always that way. It's not always this sliding scale, if you like. It's just actual clinical choices, which are changing. And I definitely noticed that on our data. When I first started at Glaucoma Australia 4.5 years ago, you know, the SLT was a lot rarer. And I think on our current stats, it's about 12% of our patients get them straight up. And so it's probably increasing. And so I think that's interesting for people to say, you know, constantly ask your physician what the latest research is, because things will change, right?
Oh, absolutely. I think the patients have to be given a choice, and then they can make an informed choice about what they want. I think that SLT, because it's got the word laser in it, that patients are afraid of that, afraid that your eye is going to be lasered. But, you know, SLT is the safest laser we do inside the eye. And Kelly will know we laser every part of the eye. So, I often think that we should change SLT to intensive light treatment or something like that. I think rebranding it would make a difference.
It's been a PR problem.
Yeah, it definitely has. You know, let's start with some intensive light treatment for your eyes.
Yeah.
We know that when we start with that, you know, at 3 years, like 80% are still not taking any treatment. I mean, statistics pretty good.
It's phenomenal. It's absolutely phenomenal. And an interesting point I heard in Kelly's presentation too was, you know, the point that, but you're not cured. It is a lifetime disease. And we'll often get people say to us, I don't have glaucoma anymore. I had laser. So whereas they're actually saying, no, well, they had treatment which was incredibly effective, but they still have glaucoma. Yeah.
Absolutely. And that is such an important message to the patients, Annie. And, you know, I don't think we can emphasize it enough. You know, it's a lifelong disease. I think that if patients get the wrong message about that, that's when we can get into trouble, because they can have SLT, think they're cured, and not come back for follow-up. Now, that could be a recipe for disaster, because at every follow-up visit, we're evaluating, have we reached our target pressure? Are you getting worse at that level of pressure? Do we need to revise that pressure? Do we need to aim lower? They're the questions that we ask ourselves at every visit. What do we need to make your nerves safe, to keep the vision that you have for the rest of your life, to maintain your quality of life and health, eye health?
I think that's such a key point that we've emphasised tonight, because I know our ambassador, Kirk Pengilly, who had laser and says, to be honest, it feels like I don't have glaucoma, but I do. And I don't miss any appointments, because he's obviously had that drummed into him. And when you feel that, you've had treatment, you're not having that drop every day, you're not sort of acting on it, it is very easy to get complacent and to feel, very comfortable that, there is nothing going wrong. But as we are all aware, we don't want to be in that moment when damage has occurred, which could have been prevented. I've got another interesting question on the chat line that says, can children have MIG surgery? Is it okay for children?
Yeah, I mean, I guess children, it really depends. As Kelly said, glaucoma is not one disease. It's, I say it's 50 different types of diseases that lead to the one characteristic change in the optic nerve. So when we look at children, I would say it's a really mixed bag of diseases. You've got congenital glaucoma, you've got juvenile onset glaucoma, then you've got other uveitic glaucoma, inflammation related to other diseases. So it really, I would say, depends. Having said that, some of the newer devices are being used in children to maybe to do the surgeries that they used to do in a newer way. For example, with congenital glaucoma, pediatric ophthalmologists, glaucoma specialists, go into the eye and make a cut in the drainage angle, and used to do it with a needle or a blade. But these days we have newer devices, and one is called ABIC, and it's been used in adults as a mix, but pediatric glaucoma specialists are using it in children to do surgeries that they do, but with newer instrumentation. I think the other stents and things like that, you could use it in children, maybe more later, like adolescent children, but it really depends on the disease. Yeah. Just as we don't use MIGS in everybody with adult glaucoma because of the different glaucomas that we see, I would say the same goes for children.
Thank you so much. I've got a fascinating question on the line from Deborah, and it's a common one that I've heard as well, that says, well, how many trabs would you have in a specific eye? If you're going to have a trabeculectomy, is it a bit like, if someone needs a knee surgery, they go, don't get it done too early because it's only going to last 10 years, and you've got to kind of put things off, and you worry about having, all the, surgery too early, whereas obviously if you need it, you need it. So is there a lifetime on a trabeculectomy? And also, if you've had one, how many can you actually have in a specific eye?
Yeah, I think actual trabeculectomies, you need space for them. So let's say actual trabeculectomy, in trabeculectomy, what we do is we create a drain made of your tissues, but we make a little flap, which is a bit like a cat flap, and fluid then drains out of the eye through the little hole we make underneath the flap, and then under the skin of your eye to create this thing called a bleb. Now, some people might be able to have 2 trabeculectomies, but another thing that we often do is we will do a trabeculectomy, and if it doesn't work, sometimes we will revive that trabeculectomy rather than create a new one. So we have quite a few surgical tools in our toolbox. We can do trabeculectomies, we can needle or revise the trabeculectomy that you already have and use more anti-scarring medication to make it work. Or we might say that's not going to work, we can put another trabeculectomy in. I would say there isn't enough space for more than 2 trabeculectomies. And after that, we would really favor putting in a tube. So sometimes I go from 1 trab to a tube. Other times I will do a second trabeculectomy. Some people go for years having revisions to keep their trabeculectomies going.
Mm. Thank you so much. We've got another question that's come in. We're pushing on for time. It's such an engaging conversation. So thank you to the chat line. You're putting in some great questions. And thank you, Dr. Ridia, for making this just so clear and easy to understand. This one's quite interesting. We'll get, people comparing normal tension glaucoma to raised intraocular pressure in their symptoms. And so does it have a difference to the prognosis and the management, whether you've got normal tension or raised intraocular pressure?
Oh, yes, absolutely. So let's think about this. About 5% of the adult population will have pressures outside the normal range, 21, but not have glaucoma. So they're the ocular hypertensives. But when we look at the patients that we treat for glaucoma, maybe a third have normal intraocular pressure, but still definitely have the nerve disease. So in actual fact, glaucoma is a pressure-sensitive nerve disease. So they're quite different things. Normal tension glaucoma is very difficult because, as Kelly said, the thing that we do mainly is lower the intraocular pressure. And whenever a patient starts with lower intraocular pressure, it's harder to lower it even further. Now, if you have ocular hypertension, we know that over 5 years, about 10% will develop glaucoma. And we know that some subsets are at greater risk than others. So if you have intraocular pressures that's in that range, you still need to be followed up.
Yeah.
And above a certain level, we would treat it regardless. Everyone has a different number. I would think about 30. I would treat it regardless. I think when you have normal tension glaucoma, we do still treat the intraocular pressure. We still want to reduce the intraocular pressure at least 30% from where you started. We know from big studies, including the collaborative normal tension glaucoma study, that though patients with normal tension glaucoma still benefit from intraocular pressure lowering. So that is one of our primary goals. But the other thing is, I think, taking care of your general health and looking after your metabolic health is really important in all glaucoma patients. So as Kelly said, look after your general health, cardiovascular risk factors, your diet. Supplements can't replace a good diet. Have a great diet, exercise, and watch out for more evidence on supplements.
Yeah, I think that's a very good advice, and also a great area to finish with. And those listening in, I know on Kelly's slides you mentioned yoga. Glaucoma Australia actually got someone from Yoga Australia. We've got 2 videos on glaucoma safe yoga on our website. We've got a lot of patient videos. We have a lot of questions and answers that are responded to by our clinicians on diet, exercise, lifestyle type questions, and more and more. And isn't it refreshing, everybody listening in, that our physicians, we often just think they're focusing on the clinical and the operation and the medication, whereas no way, a modern specialist is all about treating people holistically, very patient-centered, very engaged in the communication and the decision making, very aware of all the other lifestyle impacts that will be occurring. And so therefore it does make sense. And I know those we get this all the time. Why is it so different, and why are people unique? Because it is a challenging disease to manage, because you will have your own unique situation. And I feel very reassured after having this conversation tonight that you're in very good hands. The message is keep seeing your specialist, and I think there's the boldness also just to ask, for the patients to have that confidence to ask more questions, that everything is okay. You really want to understand why you're doing what you're doing. And that's where the empowerment comes from, right?
Yeah, absolutely. And, I think with the World Glaucoma Week being this week, it really, I think that we really have to remember it's about the patient. It's about the patient in front of us.
Yeah, Absolutely. And it is Glaucoma Week, and Australia is doing the 7 Sites Challenge. We have a challenge on at the moment. We're getting out there. I know it's been a bit drizzly, but we're trying to get out into our local communities and valuing the sites that we just sometimes take for granted. So take a few photos, register on our website, 7sites.org.au, get a team together, get a group, start having some fun and getting a bit more eye health aware. It's a good opportunity to then have those engaging conversations with your families who might be at risk. A reminder that you need to go back and see your doctor. It reminds others who love and care for you that they should support you, support Glaucoma Australia and all the wonderful physicians that we have in our network, helping to make sure that we give the very best care and support and education to those who reach out to us. So thanks so much for taking the time. Ridia and Kelly, it's been an absolute honour to have you share with our community, and I'm sure it's been extremely valuable to those who have listened in. Thank you so much.
It's been really great fun. Thanks, Annie, for the invitation.
Thank you.